When I grew up 100 years ago or something like that, I only heard the word behavior in the context of you'd better behave, right? It always meant good behavior was expected and bad behavior, you're in trouble. But of course, I remember one of the questions was, so what is this behavioral medicine anyway? Well, in my way of thinking, everything in medicine is or should be behavioral medicine, because we're not just a machine, a physiologic entity. We are feelings about everything, just as we are our body and our mind. There's no point in separating them. They go together, and whether something starts as a body problem and we have mindful responses to it, good, bad, or otherwise, or whether something starts as a fear and we have IBS or migraine or some other medical response to it, the body and mind work together. And often that's a sort of a beginning in when I approach patients, is to help them grasp the fact that they really already know that. They just don't know that they know that the mind and body works together. And I often say that just right. And purposely to be confusing enough to hold attention, right? So, which is kind of what you do with puppets, right? It's confusing on purpose because it distracts and absorbs at the same time. And it reminds me of somebody we both know, Siegfried Rochen, in Germany. When I first came to Berlin to meet him in his office, he showed me his office, and he in the middle of his office is a big trunk, like from like would be on a steamer, on a steamship trunk for travel, and he says, well, just sit down here on the pillow. So I sat on the pillow. He says, this is where I have the patients and the parents sit. And then he opens the trunk and it's full of puppets. And he takes his big arms and he picks out a whole bunch of puppets and puts them on the floor. And then he says, pick one for you, pick one for mommy, pick one for daddy, and pick one for me. And the rest of the session is through the puppets. And it doesn't take the parents long or the children long to get into it, because it's a game. But of course it's real. And that's part of that same concept of identifying or even in some way prescribing the mode of communication in a way that isn't as threatening to people, and somehow they're able to connect with it, and off you go into hopefully a therapeutic alliance, right? That works. The difference is not as much as people would think. I think the difference may be philosophical more than practical, and of course it depends on the clinician, who they are, and the person. There are some child psychiatrists whom I love and others whom I wouldn't send anybody to. So there's a lot of overlap. If you think in terms of diagnosis or conditions, there's big overlap. And let me just mention ADHD, because that always comes up. Anxiety always comes up. What I've often said to people, listen, I think it's true in most countries, but it's certainly true in the US. Right now, if you multiplied the number of behavioral pediatricians, child psychologists, child psychiatrists, and child-focused clinical social workers, if you multiplied each of them by 10 today, you wouldn't come close to providing the need for the mental health services for those conditions. Just talking about anxiety and ADHD. You won't come close because they're prevalent. And in this community alone, depends on who your pediatrician is or your family doctor. If they refer you to somebody for help with ADHD, it might be to a neurologist, pediatric neurologist. It might be to a child psychiatrist. It might be to a child therapist or psychometrist for testing, or it might be to a developmental behavioral pediatricians. And For each one of those, if you called them today, you'd get a waiting list of about 4 to 6 months or longer. More likely you would be treated differently. Their ADHD is a bad example because in most of those, you'd end up with medication. But with the behavioral pediatrician, you'd end up with medication pretty much in an even balance with all the psychological and psychosocial things that children with that disorder need. The parental support, the educational support, the individual tutoring, individual education plans, all of it. And many psychiatrists might recommend that, but you wouldn't get it. You wouldn't get it in one-stop shopping. And so some psychiatrists who work in big groups have those other people as resources down the hallway from them and set them up. So there's an awareness of the need. Not so much for anxiety. I don't ever begin with medication for anxiety, ever. And only a very small portion of the kids I see with anxiety end up on medication, even down the line as we develop our relationship. And that's true for depression as well. Many primary care people are taking care of children with anxiety and depression because there aren't enough therapists to go around. I've often told parents that I'm going to write a book that's called The 5 Things Parents would like to control but can't. And then I ask them to tell me what they think those 5 things are. And they usually get 3 or 4 out of 5 because they're parents, right? So eating, sleeping, talking, peeing, and pooping. Control is different from influence, and that's an important message, when parents are happy to hear that. They're like usually pretty helpless by the time they get to us, and because sadly their pediatrician hasn't done the right thing. If the child is wetting the bed, the pediatrician sadly says often, they ask the right questions. Do they pee in their pants? Do they pee at night? Do they pee in the closet? Where do they do it? Does it burn? Does it hurt? And they get a urinalysis. They check that out, and 95% of the time, the answers are no to those other questions, because most of the time, children who wet the bed have no bona fide physiological problem, other than the physiology of not having developed control yet. And maybe because parents have done inadvertently the wrong things instead of the right things. And so they end up feeling bad about it, and they come to us, and because the pediatrician usually just says, well, he'll outgrow it. Now, is that true? Yeah, it's true if you wait long enough. I decided I was going to continue to work with children with nocturnal enuresis by Zoom, even though I couldn't examine their belly. If the parent could tell me that they have a pediatrician whom I know, and they've had a competent physical exam, and they've had a urinalysis, then I thought, I'm going to do that, because I haven't learned how to draw on Zoom, but I have pictures that I've drawn, and I share my screen, and I talk the child through it, and just as I would in my office, but without benefit of real face-to-face. And it works just as well as in person. I've been so thrilled by that, but it was sort of an experiment last summer when we had to go completely virtual. So most of the kids who wet the bed have only primary nocturnal enuresis. They don't wet their pants in the daytime. So my question always is, I do things that they think are sort of stupid or weird. But I asked the child, could you turn around, please? I just want to see the back of your head. So they turn around. I said, if you were in my office, I'd be feeling your head too, but just tell me, is there a zipper back there on the back of your head? No. I said, so it's the same, the brain that's inside there, it's the same brain at night as in the day. You don't have a jar by the side of your bed that you put your daytime brain, you take your daytime brain out and take your nighttime brain, put that one in. Yeah. And how about on your tummy? Do you have a zipper on your tummy where you open it and you take out your daytime bladder and you put that in there, and you take your nighttime and you put that one in? No. So it's the same bladder. Yeah. Oh, Well, you remember that picture we drew of how the brain and the bladder talk to each other? And, what time do you get up in the morning? 7 o'clock. What time do you go to bed? You mean go to bed or go to sleep? Yeah, what time do you go to sleep? It's 9 o'clock. Oh, so you're up from 7 in the morning till 9 at night. How many hours is that? Well, they trust my math. So that's 14 hours. Oh, so for 14 hours, your brain and your bladder talk to each other just fine. Is that right? Yeah. I said, do they talk out loud? So you're sitting in class. Oh, hello, brain. This is the bladder. I'm full. I got to go. Take me to the bathroom. No, they don't do it out loud. Wouldn't that be boring if everybody in class, their brain and bladder, were talking to each other in the middle of class out loud? No, they do it. Do you even think it? So this is a curious question because they have to stop and think, right, about the question. Well, no, I just go. I get the pass from the teacher, or I wait till recess and then I go to the bathroom. And well, do you talk to your brain and bladder out loud there? No, I just go. And they don't say that's a stupid question, doctor, but but they're thinking that. I said, so since it's the same bladder and the same brain at night as in the day, all you really have to do, and remember when you say all you really have to do, that's the same as saying it's easy. All you really have to do is teach your brain and bladder before you go to sleep that they have accidentally got into this not so great habit of not talking to each other at night. But you don't have to introduce them to each other. They know each other.
I know it.
You can just remind them because you're going to be asleep. So you can say something like this. You don't have to write this down. Just remember in your own words, okay, bladder and brain, I'm going to go to sleep now. Before I go to sleep, I just want to remind you, bladder, when you fill up, tell the brain. Then your job is done. Brain, listen up. You're going to get a message from the bladder that it's full. When you get that message, you have a choice because you're the boss of the body. You could say, don't bother me right now. I'm having a good dream. I'm cozy in my bed. I don't want to be bothered. Just keep the gate locked on the bladder. Or if you don't mind, wake up, get out of bed, tell the feet to walk to the bathroom, turn on the light or use a night light there, zip down your PJs, open the gate on the bladder, pee into the toilet where it belongs. It's the only place it belongs, by the way, is in the toilet. When you're done, close the gate on the bladder, flush the toilet, wash your hands, dry your hands, get back into your nice, warm, cozy, dry bed. And then that phrase is repeated for solidifying it in the mind. And then sleep the rest of the night in your nice, cozy, warm, dry bed. Wake up in a nice, cozy, warm, dry bed. And be so proud of yourself when you discover that the bed is dry again. And then mark it on your calendar so that you can tell me about it next time. You can use a D for dry or a happy face or a check mark or whatever you want. And at night, when you do your talk to yourself, do not spend more than 5 minutes. And you can do it out loud if you want, or you can whisper, or you can just say it in your thinking. You got it? And they, yeah. I said, okay, tell me back what I said. So they give you the abbreviated version of it, 2 sentences instead of 4 or 1, but usually it's correct. And why is it correct? Not because they're a genius, but because they have the 2 ingredients they need, that all of us need for solving any problem: expectation, motivation, right? And I know that because I took a good history. So I never would say this to them in the first 10 minutes or 20 minutes. I have to get to know them. And I think every doctor should do that all the time. It doesn't, the excuse I used to get from even from the residents who haven't been at it that long, well, we don't have that much time. It's not about time. It's about being efficient. I never, ever talk about the problem first. I always talk about, so what are you good at? What's the best thing you do in your life? Well, what do you mean? So what do you mean is the same? I usually translate for parents. I look to parents and say, let me tell you what do you mean means. What do you mean means, do you really want me to answer that question? That's what it means, right? So what I really mean is, what do you do best in your life? And same question, right? Oh, you mean in school? I said, yeah, at home, in school, and when you're playing, whatever. So they tell me that, video games. Oh,
Yeah.
good. Are you good at it? Oh, yeah, I'm the best. How did you get to be the best? And they say, well, I just kept doing it. I said, yeah, is there another word for just keeping doing something over and over again? Yeah, practice. Ah, so you see, if they say the word before I do, they're really likely to do it. But if they are used to hearing that word attached to go practice the piano right now, not going to happen. We now have at most children's hospitals in the US have a feeding disorders clinic separate from the eating disorders clinic. The eating disorders clinic is for the older children, and primarily, of course, anorexia, bulimia, and now what is this AFRD? You familiar? Or ARFID, ARFID? Now I forget even what it stands for, but it's an amalgam of people who just it's like the older kids version of picky eating, and the feeding disorders tends to be the younger child whom you were just describing, and their focus, sorry to say, is to do it's run by occupational therapists and speech pathologists, and so they get into doing swallowing studies with x-rays, because there are some children who indeed have a physiological problem. So do all of them need that studied? No. Are the studies overdone? Yes. What do they need? Oh, well, they need somebody who knows about it, who can talk with them and will help them to be patient enough to listen and to learn. Why people think that they're supposed to know everything about what to do with their new baby when they never had a baby before. Even when people have sent them books, they haven't read the books. They're relying more on their grandmother or more often on their peers who have had babies. So they listen and they get all the bad news and the good news. And so I think these are learned behaviors that parents have. You were talking about the breastfeeding moms, but it's not just the breastfeeding moms, it's the breastfeeding dads and what they do and don't do. And so it's often all about teaching them how to listen to one another. It's all about explaining to them, your baby is new to the world and has to learn. And they learn the same way you and I learned when we were babies, by repetition, by mistake, and by being redirected. And that's your job, is to know the difference between those things. So redirection with love and patience and kindness are what's important. Now, is that behavioral medicine? No, I think that's good medicine. The value of biofeedback, which is in a very sort of fundamental way, is a machine that's giving you information about some measurement of your body. The fact is that people were doing biofeedback long before the word was invented. When a mother takes the temperature of a child, it goes something like this. Okay, older child, 5, 6, 7. Oh, my stomach hurts. I don't feel good. I don't want to go to school. Okay, let me take your temperature. Put it under your tongue. In the old days, put it under your tongue. Cook it for 2 minutes by the clock. Take it out. Mom reads the temperature, right? Old mercury thermometers, right? Then what happens? Well, it depends on the reading, right? If the temperature is 104 Fahrenheit, oh my God, go back to bed. I'll get you some aspirin or some Tylenol, and I'll call the doctor and we'll go later. We'll get an appointment, we'll go to the doctor. If the temperature is 98, 99, you're fine. Get dressed. You missed the bus. I'll take you to school. Now, in today's language, we would call that oral temperature visual biofeedback, because that's what it is. And the proof of that is that the behavior response is dependent upon the temperature reading and not upon the child, other than their temperature. So all biofeedback is, it gives a message. Why is it so current and popular? Because we have these computers and video games and that are interactive technology. And the biofeedback is extraordinarily fascinating to children. Really? That, you mean when I get excited or worried, that changes over there? How does it do that? That's the right question. I never answer those questions. I always say, how do you think? Well, how does that computer know that I'm excited or that I'm angry? Well, it measures your feeling, and your feeling is being transmitted by that electrode on your finger that's measuring the variability of your heart rate. And you can change it. You know, when you measure this thing called electrodermal activity, which used to be called galvanic skin response in the old days, when you say, okay, think about something that scared you, but that thing goes, and they go. Now, so the biofeedback games have become so sophisticated that now you have speedboat races and basketball games and all sorts of other things that are responsive to the child's physiology. And in it, you can show them that the physiology and the mind are working together, and you're getting the feedback immediately. So I often, when I don't always use it, and these days I don't use it at all because I don't have them in my office, but I often recommend for the people who can afford it that they get simple biofeedback home devices, the most prominent of which is a company called HeartMath. Maybe you're familiar with it. One word, HeartMath.com. And they have home units, and they have all sorts of education programs and all the rest of it. And children love these things, but guess what? It's a little bit like the piano. When you use it, it helps you. When you don't practice, then the next time you play, probably not going to sound as good. Oh, that reminds me. Can I tell you another thing that I do a lot? So kids say, do you like math? Yeah. Are you married? So I said, wait, what did you just do? And they never know what they just did. And I always said, what did you just do? They said, I don't know. What did I do? Well, I asked you if you're married, and how did you tell me? Oh yeah, but I didn't hear you say, the answer is no, I don't feel like talking, so head, you go back and forth, because that means no. Did you say that? No. Did you think it? No. How do you know? My brain told my head to do that. Really? Without talking? Yeah. Well, how long do you think you've known that this is no and this is yes? I don't know. I said, I forgot to tell you, I don't know is not allowed in my office. Because part of you knows. Don't you think it's true that part of you knows? It's always a curious thing to say to children, because then they have to stop and think, well, what does part of me know? What does that mean? So, but if you say it in an affirmative way, they agree with you. Don't you think part of you really knows the answer to that? Part of you inside knows? Yeah. I said, so just think back. Which do you think you learned first, this or this? And so parents are smiling because they know the answer. But I'm like, don't talk, and right. And then the kid says, I think I learned this first. And the mother goes, no. No, that's right. Babies around the world always learn no first. And why do they learn that? So parents always answer before the kid can answer. They say, well, because the kid does something that they shouldn't do, or it's not good, like they throw the bottle on the floor, baby does, and the parent goes, no, no, or they're crawling and they go to put their finger in the electrical socket, oh, and they jump and grab the child, or they're about to fall down the stairs. And those all get no, but yes isn't so exciting. And then I say, well, do you like science? Yeah. How about let's do an experiment? I'm going to ask you some questions. They're easy questions. They're no trick questions, I promise. And the answers are either yes or no. But here's what I'd like you to do. With your words, say the correct answer to the question. At the same exact time as you say that, make the opposite head movement you would usually make. Okay. Are you married? No. Is this June 2021? No. Is your name Bobby? Yes. Right. So what happens, now 5 or 6 questions were done. And I usually ask, was that easy or hard? And they say it was hard at first, but then it got easy. Right. I said, I never asked the parents to do it because they never do it as well as the children. Then I point out that this is not just a science experiment, because what you just did, let's say this child was 8 years old. What you just did is you took a habit behavior that you had for 7 years, since you were 1 year old, about. You had it for 7 years. And just from a few minutes of talking about it, you changed that 7-year habit, just like that. Now, you don't have to keep doing the opposite of yes and no. That was just an experiment. And usually you get this aha look on the face of the child. And then everything is easy after that, especially if you frame a problem as an issue that got accidentally turned into a habit. Well, so my best example of that is a few years ago I was asked to do be a speaker at an annual dental hypnosis congress in Berlin. And of course I had a plan with my PowerPoint and all the rest of it, but I also had left plenty of time for questions. So somebody said, well, what about thumb sucking? I said, oh, well, the answer works best with a patient who would like to pretend to be a 7-year-old who sucks her thumb. Would you like to? The lady who asked me the question, would you like to do that? Oh, I can. Okay. So she comes up and I introduce her. She introduces herself to the audience and blah, blah, blah. So putting yourself into that role, being 7, and staying in that role. I want to approach this just as I would in my office. So, but let's fast forward. We got to know each other. We like each other. I know your mother. I met your mother. Everybody's friends and we're happy. And you really don't like the thumb sucking either, except maybe you like it a little bit at night, but you heard that it's bad for your teeth and you don't want to, but you say you can't help it. Yeah, I can't help it. Well, whose thumb is it? Mine. Who's the boss of your thumb? Well, me. Okay, would you please show me how you suck your thumb? But here's the rule. You have to do it in slow motion. Now, do you understand what slow motion is? You know how they show it on TV with sports? When she gets about halfway, I say, stop. Now, leave that thumb right where it is and just let your eyes close. And now picture in your mind a stop sign, just like you see outside on the corner at the street. When you see the stop sign, let your head nod. Not nod your head, let your head nod. Great. Now, let your other hand come up and help this hand so they're friends because they know each other your whole life. And now let it bring it down. That's right. And when you know that very well, then let your eyes open. Huh. And they get this kind of, I said, now do it again. Do it yourself and I'll be quiet. Now, do you suck that thumb or you suck the other thumb? It depends. Oh, so good. Let's practice. Do the opposite then. They always know what opposite means. So then go. Great. That was really good. Now, do you realize that you just taught each hand a new pattern? I don't use the word habit anymore. I change it. Even if they use it, it's a bad habit. So it's a different pattern.
I'll tell you a little story similar to yours. I was doing a demo on nail biting, and the lady, she was getting married, and her dream was to have real nails when in the marriage ceremony. And then I took this part, who's going to help you and who can help you, how do you want other people to help you. And then she said, my colleagues at work. And I said, do you think they would want to help you in some way? And the group of ladies in the audience, they wanted to do whatever she wants to help her grow her nails. We didn't talk about stop biting nails. We were talking about growing nails. But then I asked her, what about your fiancé? Do you think he would also want to help you, you know? And then, yes, he would do anything for me. How will he help you? She became very silent, and she was thinking about how he will help her to stop biting nails when she's biting again. And suddenly she put her hand out like that. And I didn't understand. Nobody understood what she means. But then I asked her, what does this mean? So she said, he will do like this, and it will mean bite my fingers instead of your own fingers.
Internal resources. If the clinician is oriented and believes that we all have internal resources, then the focus can be with every patient how to help them identify their own internal resources to muster toward resolution of the issue, rather than even calling it a problem. It's important to think about goals and not obstacles. If we focus on obstacles, then what we focus on, we amplify. And therefore, all we have is obstacles. But when we focus on goals and we amplify the goals, then we can identify the resources we need to solve the goals, whether it's our fiance or not. Right? I mean, and it's so obvious that it always makes me wonder, like, why didn't I think of that before? You know?